From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, this is Dr. Linda Brubaker, a senior editor at JAMA, and I'm here today to discuss gestational diabetes and the risks of cardiovascular disease and subsequent diabetes with an expert in this area, Dr. Kartik Venkatesh. He's a high-risk obstetrician and perinatal epidemiologist at Ohio State Wexner Medical Center. Dr. Venkatesh, welcome.
Thank you, Dr. Brubaker.
Could you tell us a little bit about what got you interested in this important area of women's health?
Of course. My interest in diabetes and pregnancy really started as a resident and as a maternal fetal medicine fellow. And it was really in the clinical setting, seeing rising rates of obesity in pregnancy. And with that, type 1, type 2, as well as gestational diabetes. And the fact that, the number of pregnant individuals we were seeing with diabetes was so great that we were starting to have diabetes clinics multiple days a week. And then as a perinatal epidemiologist, my clinical interest transitioned into a population health interest in conducting diabetes research in pregnancy.
Well, let's get into the topic in detail. There's very clear evidence on the importance of detecting and treating gestational diabetes mellitus during pregnancy. On this podcast, though, I'd like to focus a little bit about glycemic health and cardiovascular health once the pregnancy is completed. Let's start out by just talking about how frequently GDM occurs.
So gestational diabetes, or GDM, is likely the most common metabolic, if not medical complication of pregnancy, now affecting almost 1 in 10 pregnant individuals in the United States every year. And that number has gone up over the past decade. And unfortunately, disparities in the rates of gestational diabetes persist and have perhaps even increased for some racial and ethnic minority groups, in particular Asian and American Indian individuals. Now, with regards to gestational diabetes and pregnancy, so many times I can say from the patient and provider perspective, we like to say, oh, you have GDM, the placenta comes out and it goes away. And that's what patients want to hear. And sometimes providers want to say that too. But in reality, gestational diabetes is not only about adverse pregnancy outcomes, but it's really a red flag for lifelong cardiometabolic health. And I think what we really try to do here is reframe the conversation with regards to GDM about being about lifelong health and lifelong cardiometabolic health for the individual and the exposed child, and how we need to think about this frame shift, not only in terms of patient care, but also in terms of our broader research and public health agenda moving forward.
So this is really a topic that all primary care physicians need to be very conversant with. They need to be able to take a history that highlights this risk factor of GDM during pregnancy. So once a patient finishes their pregnancy, what are the risks for them? If they experience GDM during their pregnancy, what type of risks are they facing?
So that's right. So really knowledge of a history of GDM and what that means for future cardiometabolic health later in life is something that every primary care provider needs to know about. One thing we highlight in this piece is that unfortunately, our rate of postpartum screening after a pregnancy is complicated by GDM is only about 50% in the United States. And that number has stubbornly stayed at 50%. So that's 50% of individuals getting screened for prediabetes or type 2 diabetes after GDM within a year after their delivery. So right there, that's a big problem. And then more broadly, in terms of what does that GDM history mean in terms of follow-up primary care, GDM itself is the biggest risk factor for developing type 2 diabetes later in life, anywhere from a 10 to 20-fold increased risk of type 2 diabetes. And then more proximally, before that lifetime risk of type 2 diabetes is the risk of prediabetes, in addition to other cardiometabolic outcomes, including hyperlipidemia, chronic hypertension, as well as ischemic cardiovascular disease and stroke in the long term. So you have these long-term risks, but then you also have more short-term risks with regards to developing prediabetes or type 2 diabetes, which may be as high as 20 to 30% within 12 months after delivery. So up to 20 to 30% of pregnant individuals with GDM have a risk of developing prediabetes or type 2 diabetes just within 12 months.
Those numbers are much higher than most physicians would expect them to be. What are the methods that are known to help reduce the risk of type 2 diabetes after a pregnancy complicated by GDM?
So we do have evidence-based interventions that we describe that do decrease that risk of not only diabetes, but also of obesity and more broadly cardiometabolic health. And that includes evidence-based behavioral interventions. So it comes back to diet and physical activity and exercise, but also pharmacotherapy. So metformin certainly works and it's safe to use in the postpartum period. In addition, we describe newer classes of pharmacotherapy that are currently being developed that we really need more data about, in particular amongst postpartum individuals. And these include newer agents like the glucagon like peptide 1 receptor agonist GLP-1 RAs, as well as sodium glucose cotransporter 2 inhibitors, SGL2s. And there is growing data about the ability of these agents to decrease the risk of developing type 2 diabetes, but we really need more data in this high risk population.
And are any of those medications safe to use during lactation?
That's an excellent question. So, really, we don't have that data yet. Lactation data is not available. And there is also some concern about teratogenic potential if individuals are not using contraception. So, this is an area that we really need more data with regards to more broadly use in that postpartum period, and then more specifically with regards to lactation as well.
So, as a primary care physician is providing care and making recommendations for an individual with a history of GDM, what recommendations are there for screening for diabetes and what type of screening should occur?
So, this is an area of active investigation where we need more data, which is in individuals with a prior history of gestational diabetes, and then they enter their next pregnancy. When should they be screened? Should they wait until the early third trimester, just like everybody else, or should that screening be occurring earlier? So, current clinical guidelines suggest that individuals with that prior history of GDM may consider screening earlier in pregnancy, akin to other individuals who may have other cardiometabolic risk factors that place them at higher risk of gestational diabetes. But really, at this point, this is an area of active investigation, which is if you find somebody that has early onset GDM, so you pick them up as having GDM in their late first or early second trimester, but they don't have overt type 2 diabetes. You pick it up, you start treating them with these tight glycemic targets, and perhaps even start pharmacotherapy. Does that change pregnancy outcome? And the best data we have to date from RCTs in the United States and abroad actually suggest that there's no difference. So picking up GDM earlier in pregnancy doesn't actually decrease the risk of adverse pregnancy outcomes. So this is an area where right now, we often screen earlier with shared decision making with patients, but we also need more data to better understand the implications of earlier screening and what does that really mean for pregnancy outcome.
And then, how about outside of pregnancy? A patient who's got a long inter-pregnancy interval or has completed their family, what is their screening interval recommendation?
So that's also another great question in terms of what should be the optimal interval for diabetes screening and more broadly, cardiometabolic health screening after a pregnancy complicated by gestational diabetes. And current guidelines advise that, screening for diabetes can be conducted in an interval of approximately every 3 years. But again, this is largely based on observational data and expert opinion, and we really need higher quality data to inform the screening interval for diabetes after gestational diabetes. In addition to other cardiometabolic risk factors. We really need to know how we should be doing that and how frequently. And those are questions that remain to be answered.
It's important that you've transitioned to the other cardiometabolic risk factors because after a GDM complicated pregnancy, other cardiovascular risks increase as well, such as hypertension. I wonder if you would explain a little bit about that to our listeners.
Absolutely. So, historically, our concern with GDM had been the transition and prevention of prediabetes and type 2 diabetes. Emerging data suggests a strong association also with developing chronic hypertension, hyperlipidemia, as well as cardiovascular disease long term. Now that we know there is an epidemiologic association, the next question becomes, what does that actually mean for clinical practice? And right now, we're in a spot where we need more data. I would say in the past couple years, we have large studies that have highlighted this association that's real. And what we next need to do is have clinical trials in the space to better identify preventative interventions to decrease these risks. And that's a real data gap, which could really inform clinical care in the space.
It sounds as if both the American Heart Association and the American College of Cardiology have taken note of these epidemiologic risk factors, and they're highlighting GDM as a risk enhancing factor that may be modifiable for prevention of subsequent cardiovascular disease. Let's talk a little bit about the importance of those large societies raising this as a risk factor and what that means for physicians and cardiologists.
Right. I think first off, what is so important is that, GDM is taken out of the obstetrical space and is now being highlighted and being recognized as part of a larger risk factor with regards to, the American Heart Association, the American Diabetes Association. So those implications are clear. And the fact that now GDM is entering this larger clinical and public health conversation is crucial and critical. The next step is, what are we going to do about that? And I think what we've done now in the last few years is really started making the epidemiologic links and understanding that GDM is not purely an obstetrical complication, but is really about lifelong cardiometabolic health. And there's even growing data to suggest the impact on fetal exposure. So there's emerging data to suggest in parallel how the exposed fetus is then at higher risk of hypertension and diabetes and obesity later in life, which is biologically plausible. So I think that's where we are. So we've mapped out these epidemiologic associations. Larger medical associations have taken note and have recognized the importance of GDM. And I think now the next step is really to fill in these gaps with real interventions and RCTs and data so that we can better understand which interventions work and which don't. And some of these may be interventions we already have but haven't tested in this population. And others may be newer interventions that we talk about, such as some of these newer pharmacologic agents, so that we can then really better inform patient care and really start to change what we're seeing with regards to the risk of GDM to long-term cardiometabolic health.
I'm so glad you raised the issue of the in utero risks, which are well understood in obstetrics, such as large for gestational age diabetes, neonatal hyperglycemia, etc. But then there are also lifelong risks for that child as well. Is there any evidence that early detection and excellent control of GDM during pregnancy mitigates those risks?
So as you bring up, our understanding has changed within the past decade that really, the impact of pregnancy dysglycemia and GDM just doesn't end with, those neonatal outcomes, but really has lifelong implications with regards to developmental programming for that exposed child, including obesity, hypertension, lifelong cardiovascular disease risk. But then the question becomes is if more aggressive treatment of gestational diabetes during pregnancy, does that change those risks? And the best data we have to date in the GDM literature suggests that that's not necessarily the case, that more aggressive treatment doesn't seem to affect those childhood outcomes. But an important caveat here is the data is limited. The data we do have is somewhat biased due to loss to follow up. So, again, this speaks to the need to have long term prospective cohorts from GDM treatment trials so we can better understand the impacts of GDM treatment on these long term childhood health outcomes.
It's so helpful. I want to close with just a very pragmatic question. If pregnancy is complicated by GDM, is there any reason that individuals should avoid future pregnancy?
For GDM itself, no. I think the most important take home is that GDM is a red flag for longer term risk of cardiometabolic disease, things like hypertension, type 2 diabetes, prediabetes, obesity, hyperlipidemia, even in the short term when you're planning your future pregnancy. So, really, to use GDM as an educable moment for the patient and provider to really think about, okay, now that we know you have GDM, what can we really do to change those risks before you get pregnant in a future pregnancy? Because there are real things we can do. There are evidence-based interventions we have so that, all too often we see a cascade in clinical practice where, the first pregnancy was just GDM and it was controlled with behavioral therapy. Second time around, it was required pharmacotherapy. Third time around, it turns into type 2 diabetes requiring insulin therapy even before pregnancy, right? So this cascade can be changed. And so I think really it's so powerful to use GDM as a real educable moment where we can really arrest the risk of long-term cardiometabolic disease through individualized intervention, be it in the form of behavioral intervention, diet, exercise, pharmacotherapy, such as, at least at this point, metformin, and perhaps in the future, some of these newer agents. So really to think about this as a educable moment where we can change an individual's risk of cardiometabolic disease through addressing GDM right now.
Well, it's been my pleasure to converse with Dr. Venkatesh from the Ohio State Medical Center on this very, very important topic that has implications for all groups of physicians, especially those who are doing primary care of individuals who have had complicated pregnancies with gestational diabetes mellitus. Dr. Venkatesh, thank you very much for joining us and sharing the work of you and your co-authors today.
Thank you so much. It was a true honor and pleasure to be able to put together this manuscript with my co-authors, Dr. Sadia Khan, a cardiologist at Northwestern University, and Dr. Camille Poe, an endocrinologist at Massachusetts General Hospital and Harvard Medical School. And I just want to emphasize that this type of work and reframing GDM within a larger cardiometabolic space truly requires interdisciplinary collaboration.
You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.